Ken Murphy here again. We'll get the ball rolling again. We do have a couple of other people who are wanting to join in that will presumably join in as they come along. Just like to welcome Dr. Thomson to the presentation, and I'll hand it over to Dr. Thomson to take the ball.
Thanks,
all to you, Dr. Thomson.
For those who don't know me, I'm Peter Thomson. I'm a general surgeon in Toowoomba and based at St Vincent's. I've been asked to talk today to you about common surgical conditions. Now, rather than bore you silly with talk about things you already know about and telling you how to suck eggs, I thought I'd talk about common conditions but focus on some of the more controversial aspects of the management and some of the situations that we all find ourselves in and may be uncertain at times about how we should proceed. It may seem at times with this talk that I'm picking on radiologists, and I want to be quick to say that I mean no criticism of our radiological colleagues in this talk. Radiology is one of the most powerful tools we have in terms of diagnosis, but I'm sure you're all aware that there are times when we get reports where we have answers to questions we didn't ask or things that come up that then complicate how we manage it. So you'll see what I'm talking about as we go through this. I thought I'd start with gallstones, which is I guess the most common surgical problem we treat probably after hernias. The indications for surgery where there's no dispute are pretty straightforward. Recurrent attacks of biliary colic. These patients will just about knock your door down to have their gallbladder out. Nobody really gets too worried about those ones. Acute cholecystitis, the only point I wanted to make about that was maybe not all people are aware, but there is a little bit of a trend towards treating acute cholecystitis more acutely than we used to in the past. The traditional treatment with acute cholecystitis used to be treatment to settle the attack down with antibiotics and then send the patient away for a period of 6 or 8 weeks and bring them back and do an interval cholecystectomy. And the logic behind this was to do with the fact that it was thought to be too difficult to do in the acute situation, maybe associated with a higher risk of surgical complications such as bile duct injury, and that by letting it settle down and bringing them back that there was going to be an easier operation second time round. Now, when laparoscopic surgery came along, that was probably reinforced to some extent, that attitude, and there was a push that if they had cholecystitis to treat them conservatively because the feeling was that it would be even more difficult to do the procedure laparoscopically in the acute situation, and by waiting you'd have a better chance than of doing it laparoscopically. However, we found really that that's not the case. There is a window of opportunity when acute cholecystitis first presents, where in most cases we can do the procedure laparoscopically and with acceptable, albeit increased risk of complications. That's not to say it's an easy operation. It's not an operation for a junior registrar. It's certainly, but for an experienced surgeon who's doing it more regularly, it's certainly a doable operation. In fact, if you do treat them with antibiotics and wait and come back in 6 to 8 weeks, it's not necessarily an easy operation. In fact, quite often after the inflammation subsides, you're left with fibrosis and thickened gallbladder, and it can be a very difficult operation. So the feeling that you're going to have an easier operation with lower complication rates by waiting, in fact, is probably not being borne out in experience. The other thing is, obviously, if you treat the patient acutely and take their gallbladder out, they get better very quickly. So you have a patient who can go home within a day or two usually, and their episode of care is finished. So from a health economic viewpoint, it's very advantageous because you've dealt with all the problem in one single admission and there's no need for the patient to return. So from your point of view, and it's not always feasible, I understand, in some of the rural areas to easily get a patient transferred through, and it's not always going to be appropriate, but think about it, and if you get a patient who you think has got acute cholecystitis, is the one where the pain has gone on maybe for more than 12 hours, they've got persistent tenderness, fever, maybe raised white cell count, see if you can contact the surgeon earlier, because there's a window of maybe about 72 hours where doing the procedure laparoscopically is definitely very feasible. If you get a patient that's been going 5 or 6 days, it's a different scenario, and it's far more likely in that case that we will just opt to treat them with intravenous antibiotics and come back at a later stage, because it does reach a certain point in the inflammatory process where it just becomes too difficult and unlikely that you will be able to do it laparoscopically. But certainly there's a trend towards early treatment of acute cholecystitis. Pancreatitis likewise. Gallstone pancreatitis, and any patient with pancreatitis and the presence of gallstones, we're pretty much going to presume the guilt of the gallstones being present. It's a condition which potentially is very serious and even life-threatening in some cases. So any patient who has gallstones and pancreatitis is likely to need their gallbladder out so that we don't have recurrent episodes. Again, the point I want to make here is that the trend is towards doing that early rather than later. The traditional teaching again was to settle their pancreatitis down, send them home, bring them back 6 weeks' time, take their gallbladder out. The problem was about 30% of those patients represented with acute pancreatitis, which could be severe in some cases. And what we actually found when we started doing them more acutely is that actually not such a difficult operation. In fact, in most cases, even after good going pancreatitis, taking out the gallbladder is not that difficult. So our trend now is to settle the pancreatitis down, and when we get them to the point where they're just about ready for discharge and you could send them home, that's probably the ideal opportunity to take their gallbladder out. Now, the advantages again are that the patient's treated in one single episode with obvious health economic advantages, and it reduces the risk of further complications. Choledocholithiasis I'll just add in there because sometimes people aren't sure which way they should proceed. If you actually detect that the patient has a stone in the bile duct or they are jaundiced, should they go to a surgeon? Should they go to a gastroenterologist who does ERCPs? The answer is there's no hard and fast rule to this. In most cases, I would prefer to have the stone dealt with first if I knew it was there with ERCP, and we're fortunate in Toowoomba that we have a gastroenterologist who is very good at doing ERCPs and has a very high success rate at clearing the bile duct. And then the issue simply is to take their gallbladder out before another stone goes down the bile duct. So again, in terms of timing, we'll try to coordinate with the gastroenterologist to do it a few days after he's done the ERCP. If there's going to be a definite delay or there are other reasons for delaying, then we'll usually ask the gastroenterologist to put in a biliary stent just to protect the patient until surgery can be done. It is possible sometimes to deal with stones laparoscopically, and if we do detect a stone in the duct when we're doing a laparoscopic cholecystectomy, we will attempt to remove the stone if possible by passing a wire basket down through the cystic duct and trying to fish the stone out. There are other ways of dealing with stones in bile ducts surgically. The laparoscopic exploration of bile duct is a very much specialised procedure that not too many surgeons do, and it is associated with higher morbidity. So my approach is that I'll usually explore them transcystically, but if I can't succeed with that, I'll look at doing a post-operative ERCP. Now, asymptomatic gallstones, which one of these should be operated on? Well, the general answer is that probably very few. You've got to be very careful with asymptomatic patients. I can't make a patient who has no symptoms feel any better from an operation, and I do expose them to the risk of complications and morbidity related to that surgery. Now, in gallstones, it's not common, but there is a risk of bile duct injury, which is a very, very significant injury when it does happen, probably around about 1 in 1,000. So you always have to sort of weigh these factors up in your mind before deciding if you're going to operate on a patient with gallstones who's got no symptoms. The textbooks always used to talk about diabetic patients with gallstones, and this was said to be an indication for cholecystectomy even in the absence of symptoms. And you'll see that in most standard surgical textbooks. It possibly came at the time when we saw less diabetes, as you know, with the obesity epidemic now diabetes is becoming very, very common, and I think the degrees of diabetes are different to maybe when the classical textbooks were written, when diabetes might have been diagnosed or seen less often of a more serious disease. The logic was that diabetics are more prone to infective complications, and that cholecystitis in a diabetic was said to be a more serious condition, plus the management of their blood sugars and all the rest. So there was an argument that rather than wait till they got sick, do them acutely, or do them so electively. I personally nowadays would probably be a little reticent about doing an asymptomatic diabetic just because they had gallstones. My view is still really to just be aware of them, and if they develop symptoms, then I would do them. What about very young patients? So you discover a gallstone in a young patient, and it's tempting to think, well, they will almost certainly have troubles with them at some stage in their life, and that's possibly quite true. But once again, you've got to, I think, just be very cautious about making that decision, and if you are going to decide that way, then counsel the patient fairly carefully about the potential complications and drawbacks of surgery. Often, however, on questioning, you will find that they've got some symptoms. In most cases, patients, once they present with biliary colic, when you question them more closely, you'll find they've had symptoms that can be attributed to the gallstones for some time earlier. What about little gallstones? They can go down the bile duct, they can block the bile duct. That's the worst complications of gallstones, is if you get a stone which causes pancreatitis, or a stone which blocks the gallbladder, bile duct, and causes jaundice, and they can get cholangitis, which can be a very serious condition. So perhaps small stones are more worrying. What about large gallstones? A big gallstone can block the gallbladder, cause an empyema, cause gangrenous cholecystitis. But the answer probably lies in the fact that all of the studies would suggest that stone size per se correlates quite poorly to the degree of symptoms, the severity of symptoms, and even whether they're going to get symptoms or not anyhow. So although these are factors you always do tend to think about and weigh in the back of your mind, the answer is, from a management viewpoint, the size or number of gallstones probably isn't important. So some people say, oh, look, I've only got one small stone, that's not really a worry. Well, maybe it is, maybe it isn't. I'd just go on symptoms. It's much easier to make a decision that way. So what other patients with no gallstones might need to have their gallbladder out? Well, not a lot probably, and that's the thing. Generally, we're pretty reticent about recommending cholecystectomy on someone who does not have gallstones, because generally it's the major significant pathology that could cause gallbladder symptoms. There is one condition called porcelain gallbladder, which is a nice one because it's very easy to diagnose. It shows up on plain X-ray, it'll show up on ultrasound or CT, and it's a condition in which the wall of the gallbladder becomes calcified, and it looks like an eggshell, and it feels like an eggshell if you feel it. It's said to have an increased risk of gallbladder carcinoma. Now, gallbladder carcinoma is extremely rare. We'll encounter a few of those as a surgeon in our lifetime, and mostly they're found just incidentally when we take a gallbladder out, and it's quite a horrible, nasty one, and we find on pathology it's got cancer in it. It is quite difficult to diagnose gallbladder cancer, and generally, unfortunately, as a result, it presents late and it's almost usually untreatable by the time it's found. But porcelain gallbladder is said to have an increased risk of gallbladder cancer. There's no patient that you can see who you mention that to who's then happy to have that gallbladder still in their body. So porcelain gallbladder is a relatively easy one to, I think, make an argument for taking it out. What about the patient who's got all the typical symptoms of a gallbladder problem, but you can't find any gallstones? Now we commonly see those, not uncommonly see those, and obviously we're going to consider doing an endoscopy, make sure there's no other obvious cause for the pain, but generally there won't be. You can consider doing a HIDA scan. Now it's almost historical maybe, but a HIDA scan is a nuclear medicine scan which shows the function of the gallbladder, and generally it's said if the gallbladder shows function, it's unlikely to be pathological. And although it may not be as scientific really as we would like, I think it's a nice corroborating evidence that if you do a HIDA scan and it shows a non-functioning gallbladder, in a patient who has symptoms suggestive of gallbladder but without gallstones, I think it is a little bit of extra, it's just something that's nice, reassuring, to maybe help support your decision if you do want to talk to them about having their gallbladder out. I'm again very cautious about patients without gallstones, but if they have got typical symptoms and there's some other pathology, and the other pathology we'll get to in a moment, but on ultrasound you can sometimes see other features suggestive of gallbladder disease which might push you that way, and that might come up shortly. So we'll go into that in a moment, because we're going to talk about what are the radiological abnormalities that sometimes causes grief when we do an ultrasound and we get this report, we're not sure what to do about it. One of them is gallbladder polyps. There are probably different types of polyps, and I'd say right from the outset that sometimes polyps are actually stones, and they can actually be stones in the gallbladder. So if you've got a patient who has symptoms and they've got what has been reported as gallbladder polyps, I think it's reasonable to consider just referring that patient to have their opinion about having their gallbladder removed, because what we'll sometimes find, in fact, that what we thought was a polyp was actually a gallstone. Obviously, when the radiologist looks at the ultrasound, or the radiographer really, when they're doing an ultrasound, a polyp is so closely associated with the mucosal wall. It doesn't move around when they poke and prod with the transducer. It's a fixed position, and that's how they sort of come to decide it's a polyp. It may not have the same shadowing as a stone as well, but they can be overlapping. It can be difficult. And in fact, some of the gallbladder polyps at least are due to cholesterol stones which deposit within the mucosa of the wall of the gallbladder. And there's a condition which the radiologists, and it's a histological thing as well, but the radiologists report it not infrequently, called adenomyomatosis or adenomyosis, in which they can actually see, the pathologist can see, no, not the pathologist, I should say, the radiographer can see on the ultrasound that there's thickening in the wall of the gallbladder. There may be like little cholesterol polyps, or that's what they turn out to be, cholesterol deposits submucosally, and over time there's this infolding of the mucosa which forms these sinuses like a diverticula through the intramural, through the wall of the gallbladder. And the radiologist can actually see that. They've got this lovely name for it. They call it Rokitansky-Aschoff sinuses. So it all sounds fairly dramatic when they report it. The actual significance of that is really unclear. It's probably part of a spectrum of gallbladder disease, and it may be incidental and it may be of no significance, but if you have a look in more detail at the histological reports that come back on your patients after they've had their gallbladders removed for gallstones, it's a very common finding that they'll describe these sinuses and these thickening of the gallbladder wall and these little deposits of submucosal cholesterol. And I've even seen patients where they've got actually like a little stone in the wall of the gallbladder. So I suspect this is on the spectrum of gallbladder disease, and the significance is that it's of no significance if they've got no symptoms and it's just an incidental finding. But if they have got symptoms suggestive of gallbladder pathology, and you find that adenomyosis or cholesterolosis or those sort of things, then you could certainly make a case for considering that patient for cholecystectomy. But what about the other type of polyps? Well, the other type of polyps are the adenomatous ones, and these, in the same way that adenomas in the colon can turn into carcinomas, they are known to have a risk of developing malignancy. Once again, it's a very rare situation for that to occur, and it's generally said that under a centimetre in size, if it's a gallbladder polyp, the risk of malignant change is exceedingly low, to the extent that it is perfectly reasonable to leave them alone. So the general advice at the moment is, if you have a report that shows gallbladder polyp or polyps and it's less than a centimetre in size, it's perfectly reasonable, if they've got no symptoms, just to observe that patient. And what I'd recommend would be an annual ultrasound. Now, if they do show signs of significant growth, certainly if they get over a centimetre in size, or again, if they're increasing in number, or if they're developing any symptoms, these are all patients that should be considered for cholecystectomy. Otherwise, It's a bit of a pest for the patient. They've got to have a regular scan, and they do maybe worry a little bit about them, but it is perfectly reasonable to watch them. Porcelain gallbladder we just mentioned on, so I won't be able to touch that again, but pharyngeal cap's just a cute one that you'll sometimes see reported, and it sounds a bit spectacular, but it's simply describing the shape of the gallbladder, and I'm not great on my history, but I think it's back in the medieval times when there was a certain funny shaped hat which was a bit conical and had a peak which stuck out at the front. And sometimes the gallbladder folds back on itself where the cystic duct sort of comes up and joins with the gallbladder, and it gives this appearance which a radiologist can see, which is the same shape as this particular hat. That's what they mean by cap. It's of no significance whatsoever. It's just a clever thing they like to report, and it doesn't need to be treated. So we mentioned quickly about gallbladder polyps, so we won't go on with that any further. And we talked about adenomyomatosis. Again, as I say, I think this is on the spectrum of gallbladder pathology, but don't overread it. So if you see that on a report and the patient's got no symptoms, then there's no need to sort of do anything about it. But if you do see that on a report and they've got some symptoms, it might be if they're only mild that you just watch them, but this is a patient who might be an evolution of developing gallstones, or they may already have gallstones. We'll just move on to groin hernias now. That's another common surgical problem. Once again, the easy ones are the ones where they're palpable. There's a reducible lump in the inguinal region, reappears with an increase in abdominal pressure, reduces on lying down. If it's an inguinoscrotal one, it might even extend to the scrotum. These are all easy hernias to diagnose, and the treatment of these is straightforward. We simply would recommend surgery for the vast majority of inguinal hernias, so that's not hard. The hard ones are, what if there's no obvious lump there? They've just got pain in the groin. That's a hard one. And what should you do with that patient? Send it straight off for an ultrasound. Seems to be what happens a lot now. I think even harder again is you've got a completely asymptomatic patient, but they've found a hernia on ultrasound. I'm sure you've all seen that. Ultrasound shows a 6 millimetre defect at the internal ring containing a small bit of fat. What do you do with that? So do you operate or not on hernias? Well, this is a straightforward question. So most hernias, if patients fit enough, really should be operated on. We know indirect hernias, those are the ones that come through the internal ring, definitely are more dangerous because they can incarcerate and strangulate more readily than the direct hernias. And so definitely children and young adults, where they're virtually all indirect because they're congenital in nature, should really be operated on. I think we all know that you will occasionally come across them probably in your elderly nursing home patients maybe. They don't really do anything much manually. They don't lift. They've got these direct bulges in the groin. They've had them for years. They don't cause them any pain or trouble. You're pretty confident that they're a direct hernia. They're unlikely to be a complication in that patient. It's perfectly reasonable to leave those alone. But a younger patient with a direct hernia, they won't ever go away. They will get bigger. They can cause complications and symptoms. Far better just to operate on them. But what about ultrasound and hernias? Because I'm noticing a little bit of a trend these days that nearly a lot of patients are getting ultrasounds, and unfortunately I think we're even seeing some doctors, I think, who feel that when you make a diagnosis of a hernia, the next step is to do an ultrasound, and that maybe the surgeon wants an ultrasound before they see the patient. Well, I'd just like to point out that that's not the case. Surgeons love examining patients for inguinal hernias and pride themselves on their ability to elicit the signs and things from an inguinal hernia. So we get far more grief from ultrasounds done which suggest perhaps a hernia when we can't clinically demonstrate a hernia, and then we're not sure of the significance of it. You've got to realise that ultrasound is very operator dependent. The patients are nearly always disappointed, I find, when they're clutching their ultrasound and, do you want to have a look at it, doc? And I say, no, I don't. I can feel your hernia. It just needs to be fixed. Similarly, if you've got an ultrasound there which shows a small hernia, it's still not much point for me looking at it, because unless you're actually there at the time when the operator is looking with the transducer and moving it around and asking the patient to do a Vasov or a strain or whatever, it's just looking at a weather map. It's not like looking at a CT or an MRI scan where we can really have a look at the pictures exactly the same as the radiologist. It's an operator-dependent thing. Now, that can be good or bad. If you've got a brilliant operator, and I went to a hernia conference in Sydney recently where there's a radiologist down there who's a sports radiologist and sports physician, and basically just does groin ultrasounds day in, day out. Now, he does very involved examinations with high-resolution equipment, and it takes him about 30 to 40 minutes to do an examination, and you get a full foolscap page report back saying what his findings are. Now, I'd like to contrast that with probably what happens most of the time here, where you may have quite a junior radiographer with limited maybe experience or even interest in the area. They will do 10 minutes because of the pressures of the turnover time scan, and you'll get a 3-line report, generally, as we talked about before, showing a small defect containing a small bit of fat. Now, as I say, I'm not here to attack the radiologists on that. It's just a comment. It's just the realities of life. And the problem, I think, is that many of the things they see radiologically are of no significance to the patient in terms of symptoms or signs. Marked groin pain, this is my opinion, in the absence of a clinically demonstrable hernia, is almost always likely to have another cause. In other words, if a patient has a hernia and they have symptoms from it, it's generally very obvious. You can see the hernia, you can feel it, you push on it, it causes tenderness, and it's uncomfortable. So if they've got really severe pain and it's not an incarcerated hernia where you've got a lump that you can feel, think of other causes. Now, the common ones are, they're the young athletic males. They commonly get these conditions, pubic osteitis, adductor tendonitis. These are the sort of musculoskeletal ones where they get little tears in their fibres. And you can sometimes detect those with a high resolution ultrasound if you know what you're looking for. I would probably consider doing an MRI on some of those to see whether or not I can actually detect it, because they can be quite difficult to diagnose as well. But they're far more likely, I think, than a patient who has nothing to feel and nothing to see with severe pain and tenderness, probably not going to be a hernia. So how do you get out of trouble with ultrasounds? Well, I think the thing is not to do them if you can avoid them. So don't do them routinely, because you will then get reports where you're not sure what to do with them, and the patient can often be disadvantaged by this. The other situation is, which is a controversial one, is sometimes they're done as a screening procedure now by potential employers who don't want to be caught with a workers' comp situation. So I have had patients, and they're in a very difficult situation because they've got no symptoms, no signs. They've got an ultrasound that says they might have a small hernia there. The employer's not going to touch them until they've had it fixed. So they're in a really tricky one. If you've got a high clinical suspicion of a hernia but the signs aren't certain, that's certainly one that I think it'd be reasonable to get an ultrasound for. Now, the problem again being is how much well you know your radiographer and trust them, and that's a bit difficult thing if you're like me, because I never know which radiographer is going to be doing it. If you are lucky enough to live in Sydney, well, you might be able to send it to that particular guy who's so good at them, but it's a reality of our existence that we probably don't have that luxury. If they've had previous surgery and you're wondering about a recurrent hernia, now that can be quite a difficult thing to decide. I think that's a reasonable thing at times to maybe consider doing an ultrasound to see whether you can see anything there. And with unusual hernia types, now the main one there would be a Spigelian hernia, which is not really a groin hernia, but they're generally, these are ones where they come through lateral to the rectus abdominis muscle, most commonly just below the level of the umbilicus where the semilunar line is. but they can occur anywhere along the length of the rectus abdominis muscle. Now these patients often do get quite significant symptoms, but often when they come to you, you don't see a lump and you can't feel a lump, and the hernia generally comes out and it's trapped between the layers of the anterior and posterior rectus sheath. So they're a bit of a difficult one to diagnose, those ones. Ultrasound may show the defect, so it's certainly worth doing, but even ultrasound can be very difficult to see it. What type of repair should we do? Well, I don't think there's very much doubt now that mesh really has become standard. The traditional repair going right back to the 16th century was suturing the defect up under tension, which had a high recurrence rate and caused a lot of pain. Mesh, which aims to sort of cover the defect without actually trying to close it, very definitely has a lower lower complication rate. The concern with infection getting into the mesh hasn't really proven to be a case in inguinal hernias. Certainly it's a problem for incisional hernias, but not for inguinal hernias. The best type of mesh still in evolution. The concern is chronic pain after inguinal hernia repairs is very common, and a lot of that is thought to potentially relate to the mesh, maybe the scar reaction to it, nerves getting caught up in it, the mesh being too rigid. How much of this is actually right and how much is driven by companies wanting to bring out the new improved mesh? Look, it's pretty hard to say. You could be cynical, but it is an evolution. There's a lot of work going on about this. There's a trend towards using softer meshes. There's a trend to using meshes that are partially absorbable. There's even a bit of a trend to using biologic materials which will become incorporated in your own tissue. All of this is still being worked out, and how you fix the mesh in there, because part of the problem, particularly with laparoscopic repairs, is related to the method of fixation of the mesh, where we've used little corkscrew staples and things which in themselves has caused pain, and things have stuck to the staples and caused obstruction. So we're looking more now towards absorbable tacks and things that are going to do that. So a lot of work going on, probably of no great relevance to you as a GP, but that's certainly something just to be aware of. Open versus laparoscopic surgery, your patients will ask you about that, which is better. And it's interesting when you talk to surgeons, they tend to often fall into one camp or the other. They're stronger. You get some surgeons, I do every case laparoscopically, and I'll do every case open, and they're very black and white. I've never quite understood that approach. I see their advantages and disadvantages with both procedures. Always seems to make sense to me to actually look at the patient you've got and the type of hernia they've got and try to work out what the best approach is for that. So I think there's definitely a place for both. If you're asking what's done on a national scale, still the vast majority, more than 60%, are done openly. Laparoscopic surgery, the traditional approach was actually a true laparoscopic approach where we came intra-abdominally and repaired the defect from inside. And in fact, in a lot of ways, this operation was perhaps the one that was going to have the best long-term results in terms of decreased recurrence rate, and certainly from a technical viewpoint an easier one. But historically had a very interesting story, which I won't elaborate too greatly on in the interest of time, but involving a very famous Australian Test cricketer who in the early days of laparoscopic surgery had a laparoscopic repair and had a rather unusual complication where a staple fell out that was holding the mesh in, and an adhesion formed to it, and this all unfortunately unravelled while he was on a Ashes tour in the UK, and had a giant laparotomy done by one of the English surgeons, and he subsequently sued the surgeon from Australia. And after that, pretty much overnight, surgeons went to doing a different repair where they do now, which is what the majority of surgeons now do, which is a pre-peritoneal repair, where you come down behind the muscles but stay in front of the peritoneum. And from a technical viewpoint, this is a lot more difficult operation to do, has a much longer learning curve, you have to do many more before you become really good at it. And it's my opinion that it probably does have a higher recurrence rate, then both the true laparoscopic internal repair and the open repair. But it's still quite a valid operation. Spigelian hernias, just to touch on, are those really difficult to diagnose ones. You can try ultrasound, CT, even MRI, but if you've got a high enough suspicion, the thing these days is a laparoscopy really gives you a great view of the anterior abdominal wall, and you can have a look at that from the back, and you can see this neat little hole from a Spigelian hernia. And almost without a doubt, laparoscopic hernia repair is going to be the way to go to repair those, because it's very easy to put a piece of mesh over the back of them. And one of the good things that's happened in the last 4 or 5 years is the development of these composite meshes which have layers, and they have coatings which resist the bowel sticking to them. And in combination with the new absorbable tacks, which don't have the problem that the old metal tacks have that you used to often see on x-rays where the bowel would stick to them, these sort of new tacks which absorb will hopefully see that we'll get less complications from them. These patients recover very quickly from these types of repairs, and compared to the old open repairs, which were really quite tricky with Spigelian hernias, I think it's certainly the way to go. And it's true probably to say also with incisional hernias that the trend now is towards a laparoscopic approach. There are better meshes available, as we mentioned, better fixation rates. Don't get me wrong, there are still high recurrence rates. At the hernia conference I went to recently, it was interesting to hear the experts, and these were international experts as well, talking about this, and it was really, they were really quite pessimistic about incisional hernias, even to the extent of one guy who said that basically they all recurred with time. So it is a very difficult problem to fix these incisional hernias. It's compounded by the fact that we've got an obese population who seem to be still getting fatter all the time, and they do have high complication rates. They do make it very difficult to repair. I mean, part of the reason why we see quite a high incisional hernia rate is to do with that. We are working more and more, if we can now, to doing a laparoscopic repair from the back. It is probably gives a better outcome than doing a big cut from the front, but there are times when open repairs are still necessary. Parastomal hernias, just to mention them, are very common. So you would all be aware, probably your patients have got permanent colostomies. Perhaps, or even the majority of them perhaps, will have parastomal hernias. It's the nature of the type of problem, because you're bringing this colon out through the muscle wall. It's virtually impossible. You can't have it tightly closed around the bowel, and so it's very common to get a hernia slide alongside that. The vast majority of them are manageable just with simple conservative measures. Obviously, you've got to try to avoid these patients putting on too much weight. They are very difficult to fix. If you do attempt to fix them, you've generally got to try to use some form of mesh to encircle the hernia, circle the stoma. You may even need to consider resiting the stoma. That's a fairly major operation itself. So generally, with patients with parastomal hernias, we try to leave them alone. There is a trend currently to consider the use of prophylactic mesh insertion at the time of construction of the stoma, and that's certainly something I'll be looking at more, because I think there's some probable benefits in that. Appendicitis, another common condition. Just remember, the history and clinical signs is still your best governance. There's no perfect test for appendicitis. If you've got a patient you're thinking it's appendicitis, you're not sure, CT is probably the best investigation. Don't feel you have to do it. If you've got good history and good signs of appendicitis, just send them to a surgeon. I don't need to have radiological confirmation in that situation, but when there's any doubt or there's potential other complicating factors, CT is probably the best way to go. We're concerned about ionising radiation from CT, and especially in children, and that is something that's becoming something we're more aware of in recent times. So ultrasound is probably better in children from that point of view, that you avoid the ionising radiation. And children, fortunately, most of them haven't quite got to the obese standard of their adults, so that ultrasound tends to be much better. I think it's fair to say that laparoscopic surgery is now really the standard treatment for appendicitis, and there are good reasons for that. They do have less wound complications, and wound infection after laparoscopic appendectomy is actually extremely rare. Obviously they get better cosmesis. Often these patients have virtually no scarring to show for it. It's important to emphasise that the recovery is the same. People tend to think laparoscopic surgery is associated with faster recovery, and by and large it is, but the thing that drives how long it takes to recover after appendicitis is the severity of the appendicitis. If it's a mild case, you'll be better in a day or two. If it's a severe gangrenous ruptured one, you're going to be crook as a dog for 5-6 days. They'll have an ileus, they'll have fevers, they'll be unwell. Now whether you've done it openly or laparoscopically, it won't make a big difference. Do they get an increased pelvic abscess rate after laparoscopic surgery? Now I came through at the time when I did all my first appendixes open, and then when they first started doing laparoscopic surgery at the Royal Brisbane, I was lucky enough to be a registrar at that time, and we started doing them laparoscopically. And we certainly talked about this amongst ourselves, that we felt that potentially there was an increase in pelvic abscess rate after laparoscopic surgery. Now the reasons for that have been suggested that it may be to do with the gas, the pneumoperitoneum, blowing the bugs around the abdomen. Is it because we don't suction as well as we used to, or is it because we actually wash out more and we wash the stuff around? The answer is nobody's quite sure, but it's possible, or it's probable, that there is a slightly increased risk of pelvic abscesses. But despite that, it's unlikely that we're going to go back to doing opening procedures for all the benefits that we get with laparoscopic surgery, and the fact that our patients, our adult patients, are getting bigger and fatter, and there's definitely it's nice to do them laparoscopically rather than make a big cut that's likely to get infected. In fact, most of my registrars now, if they have to open an appendix, have to call me in to help them because they can only do them laparoscopically. I just want to sort of finish off with the acute scrotum. And that's just to say that torsion of the testis is a thing you've got to exclude. So someone who comes with acute testicular pain or acute scrotal pain, just think torsion of testis all the time. Typically this is going to be a young teen, usually around 13 years of age is probably the peak age. It's very rare over the age of 20. I'll occasionally get a call from the country and they'll say, I've got a 52-year-old man who I think's got a torsion of the testis, and I'll almost just say, no, he hasn't. You've got to be very careful, obviously, in medicine, just saying no, it never happens, but it pretty much never happens. If you get through to be in your 20s and you haven't had a torsion, you're not likely to get one. It's because there's a congenital abnormality in the way that the testicle is invaginated by the tunica vaginalis, and as you know, if it extends too far around the testicle, then the testicle can lie in an abnormal lie, typically in the most dramatic situation as a bell clapper testicle that lies horizontally, but don't expect that you have to see that for it to be a torsion. And they do typically present in childhood or early teen years. Also remember, epididymitis is very rare in children. In fact, I always tell my registrars, don't make the diagnosis. To make the diagnosis, I would want to see that they've got white cells in their urine and bugs in their urine, and you actually can culture a bacteria in their urine, because epididymitis in itself in a boy indicates usually that they've got an underlying urological abnormality. They may have urethral valves, or they may have ureteric reflux or something else giving them urinary tract infections, because it's actually just very rare. Yes, you can get viral things, but again, mumps or otitis, very, very rare these days. So it's better not to make the diagnosis. I think as a surgeon, if you explore a testicle and you actually find that they've got epididymitis, no one will criticise you. But the big danger is if you make a diagnosis of epididymitis in a child and they've got a torsion which you miss, you won't get thanked by anybody, and you will be found culpable by the medical legal system. It's just not at all sympathetic to anyone missing a torsion testicle. So just think of it, and the best thing to do is just for you is to pass the responsibility on to a surgeon or urologist to assess that child. again, ultrasound's unreliable. In fact, I'm quite strongly would say don't bother with it. It seems really appealing. Ultrasound's getting better all the time. We've now got Doppler. We can look at blood flow in and out of the testicle. It's been shown time and time again through multiple studies that ultrasound is unreliable in diagnosing torsion of testicle. Yes, it sometimes can. Sometimes it can show you've got a dead testicle. Sometimes it can show, but the problem is in the early stages often there can be inflow, and yet the first thing is they're getting venous congestion and they're not getting outflow. And in fact, if anything, the testicle might even look a little hyperemic, and the report might suggest that the testicle is a bit hyperemic. It's clearly more likely epididymitis. So that's a really dangerous report to get. The best thing to do is don't do it at all, and then you're not worrying about that. You've got roughly 4 to 6 hours before the testis loses viability, so don't muck around with these ones. Don't send them up to the emergency department to sit and wait up there. Ring a surgeon directly, get them to make an arrangement to review the patient. Now, in most cases, fortunately, it's not a complete occlusion of the vessel, so you have actually got a bit longer than 4 to 6 hours, which is just as well because, as you know, children or boys are often shy to report this problem and may have been going for some more hours before they report them. So, fortunately for us, the complete occlusion situation where you only got 4 to 6 hours is not the usual situation, and you can often save a testicle even where they've had symptoms maybe up to 24 hours. But it is still a surgical emergency, and we will, once we've suspected that they've got a torted testicle, push to get them into the next available theatre. The more common cause for acute testicular pain, of course, is torsion of a testicular appendage, what's called the hydatid Morgani, and that's a little embryological remnant. It's at the girly bits that are left over, and they appear just as a little stalky bit with a mushroom-shaped head on the top of it. Usually they can be on the epididymis or the superior pole of the testis, or just in that little area between the epididymis and the testis. Typical age when they tort seems to be 11 years. It's just really common that that's usually when they happen. And it's not known why, but it may be a little surge of hormones at that age. Potentially they can swell up and then they just simply twist around on their stalk and they become ischemic. Sometimes you'll get the blue dot sign where you can actually see the little blue ischemic appendage sitting on the top of the superior pole of the testis, and it's quite tender. If you're a surgeon, you can sometimes, in your experience of examining, you sometimes be pretty confident that that's what it is. You can feel the testicle between your finger and thumb and give it a little gentle squeeze. It's non-tender, and then you sneak up towards the top of the testis and you suddenly feel this very tender little spot, and as I say, you might see the blue dot sign. It is possible to treat them conservatively if you are completely confident with your diagnosis, and what will happen is they'll have pain for roughly a week, and then the little appendage will shrivel up and become atrophic and then disappear. However, most surgeons would probably opt to explore them because you don't want to get caught with a red face and miss a torted testis. And the other thing about it is if you do just remove this little testicular appendage, you can stitch the testis so that you're not worried about torsion in the future. Usually I'll duck over the other side, pick the other one out as well because they usually have them bilaterally, stitch the other testicle. They're never going to bother you again because pretty much once you've done an orchidopexy or stitched the testicle so that it can't twist, they are safe. They will never have a torsion of the testis. So I would again say don't make the diagnosis unless you're a surgeon. Still send it to a surgeon and don't do an ultrasound. That's the main thing I want you to get out of this is don't do ultrasounds for acute testicular pain. Epididymitis is usually going to be an older male. So these are the old blokes who've got a large prostate, and that's the source for them bladder outflow obstruction, urinary tract infection, then they get epididymitis. Now, unfortunately, it is becoming a lot younger in our male population who are sexually active, and the usual cause now is chlamydia. So young male sexually active, yes, you can make a diagnosis of epididymitis. It can be hard to diagnose because chlamydia is not an easy one to diagnose or to get on a culture. But again, just go back to the fact that if they're a child or a young teen, don't make the diagnosis. Be very careful. You've got to have pretty strong evidence supporting it. And even then, you probably need to refer that child onto a paediatric urologist for further assessment. That's really all I wanted to say today, and I'm happy to take any questions now if there's anyone got anything they want to ask. Okay, I'm assuming there's no questions, so thank you very much. Bye-bye.